All right, good morning, everybody. We're going to get started in a second. First, I'll introduce myself. My name is Cathy. I'm a first-year student at Fuqua here, and I am the social track manager who's in charge of getting all these wonderful people in the room this morning. And I am going to hand it over. We're going to have about an hour of questions, and we're going to leave some time at the end for you all to engage in the discussion. So without further ado, I will hand it over to Paul, our moderator.
Okay, great. Thank you. And thanks for all the work you did putting this together. The title of the session is It's Scalable, Duke and Global Health, and our panelists are Richard Bartlett, Cathy Clark. They're sitting in order. Karen's Bob Malkin, and Clune. Let me give you a bit of background on all this, and then without any further ado, we will have each of the panelists give about a 5-minute introduction, and then I have a series of questions that I'm going to raise with the panel, and they will chime in where they feel it's appropriate for them to chime in. And some of you may want to chime in during that part of the discussion too, and we will definitely work hard to have enough time left over for questions and answers, because I'm sure you will have many questions. But let me give a little bit of background to start out. The U.S. Agency for International Development, USAID, has a long history of working on development problems around the world. And a lot of the work they have done historically has been with contractors and consultants, but not as much with universities and colleges. And so in their wisdom, a few years ago, they decided to set up something called the Higher Education Solutions Network. And they had a call for applications for that, to become part of that network. And the idea here was to have stronger relationships with universities to take advantage of all the knowledge generation and thinking going on at universities, but also to get students engaged, to get other parts of the campus engaged, and call on talent for helping USAID pursue some of its initiatives, particularly in science and technology. Get more talent working for these kinds of very important issues and problems. So they had this request for applications, and we at Duke put together a team to apply for this program. And we were one of 7 universities that were selected amongst a really large number. Karen may be able to give us the exact total number, but
there was many.
Yeah, and we were very thrilled to be selected to be part of this network. The label we're giving to our initiative is SEED, the Social Entrepreneurship Accelerator at Duke. And the focus of our initiative or our program is around global health. And we are working in collaboration with the International Partnership in Innovative Healthcare Delivery, IPIHD, which Richard is the executive director of. And we are working with them because they have identified a group of organizations out there that work in global health that are quite innovative, especially in the way they deliver healthcare services. And we want to help these organizations scale. It's a collaboration between IPIHD, CASE, which I work with, and so does Cathy, and then all other parts of the university. Malkin is from the engineering school. You're also part of the Global Health Global Health Institute. So that's another major player in what we're doing. And the goal here is to take these organizations that we're working hard to identify that have readiness to scale, and to help them develop strategies for scaling and also strategies for attracting investors. And so that's partly where Cathy comes in, and another partner which we have, which is the the Investor Circle, which is an organization headquartered here but has a long history of helping to move organizations in the social sector along toward attracting capital and in particular equity investment. We're all working together to move these organizations along. Now, Karen is also involved with a program at USAID called Saving Lives at Birth, and there are several organizations associated with that that will become part of our cohort of organizations that we work with to try to support and help in their scaling efforts. So that's kind of the background on this. And I got questions that we'll raise about why scaling, what are the challenges in global health, and so on. But first, I'd like each of these folks to introduce themselves, talk about their role in their positions at Duke or at USAID, and then also what their role is with the SEED program, and then any other thoughts they have about what most excites them about this SEED initiative. So we'll start with Richard.
Thank you very much, Paul. For those of you that don't know me already, I'm the Associate Director for the International Partnership for Innovative Healthcare Delivery, and I'm going to be the Associate Centre Director working directly with Cathy on this new SEED initiative. IPIHD is a somewhat new non-profit organisation that's hosted here at Duke University. We were spun out from a World Economic Forum at their annual meeting in Davos 2 years ago. And really the purpose for why we exist is when you start looking around the world in healthcare, there's huge challenges. Either in sub-Saharan Africa, where getting basic access to care delivery on the ground in villages is almost non-existent, to countries like India and China, where you're trying to deal with an explosion through of economies, as well as huge demographic population growth. How do you make sure that the health system keeps up with that in an affordable way that's ensuring quality? And then when we look at our own country, the US or Europe, we've got rising costs, and quite frankly, the money that we put into the system is not getting the types of outcomes that we want. So what we then began to do was say, well, what are the lessons from around the world? What are some of the principles that can be either scaled up or translated to other geographies? And the very fortunate news is that there's a huge number of models of healthcare that are breaking what we refer to in health policy as the iron triangle of cost, access, and quality. And really what my organisation tries to do is identify, learn from, and support the growth of these organisations. We do that on the one hand as being an accelerator, where we provide business mentoring, coaching, access to an online platform, access to investors, in order to help along this accelerated journey of growth. But we also act as a think tank, so studying how these lessons can be translated from one country to another, including looking at what is the role of innovation back in health systems such as the health system just down the road at Duke. We were particularly excited about being part of this initiative because we see it as a real opportunity to enhance and amplify the impact that we can have as an organisation working in partnership and collaboration with folks across the university as well as USAID. And let me give 2 examples of that. Through all of the work that the Centre for the Advancement of Social Entrepreneurship has done over the last 10 years or more, there's an entire field of understanding what does it take to get some of these organisations to the next level. How can you bring funding in a systematic, appropriate way to scale organisations? And what is the type of ecosystem that enables or distracts innovation taking place? It also gives us on-the-ground access as well as centrally to USAID through their field missions, looking at ways to use missions to translate lessons into healthcare reform in different countries, but also then using the Bureau and its convening power and its platform globally in order to bring much more value and excitement to this area. So I think in summary, for us this is an incredibly important initiative. We haven't globally achieved in healthcare what we need to achieve. We're a long way, we're going to fall short of the Millennium Development Goals across the board in healthcare, but we know what the solutions are, and we understand how solutions can be scaled, and now is the time to try to bring this together in a pragmatic way and move towards impact. Thank you very much.
Great. So I'm Cathy Clark, and I am a professor here at Case, and I teach, I've taught social entrepreneurship both at Columbia Business School and here at Duke for coming on around 13 years. I've also been an impact investor, both as a foundation executive and as a fund manager, and I founded and run our Case I3 initiative on impact investing, which we started here 2 years ago. And then the last piece of my role is I've also been extremely active in developing the field of impact investing, and have been chair of the board of Investor Circle for quite some time, and actually brought them into this project. So very briefly, I have two main roles as part of SEED. The first is bringing the knowledge and research that I've been doing for the past 20 years on how social entrepreneurs scale to this particular series of cohorts of entrepreneurs. Greg Dees and I have done a lot of work on business models. Greg and Paul have done a lot of work on scaling. I've probably worked with hundreds of social entrepreneurs, both for-profit and nonprofit through the years. And so we're excited about trying to say how can we bring the right tools to people at the right point in their development, and actually kind of understanding what their needs are and trying to kind of fit that together so that we have an integrated set of support systems, as opposed to what happens now, which is everyone goes, I'm a social enterprise, now what? Now what do I do? And kind of make that more systemic. The second piece of my role is really the coordination with the portion of those enterprises that may be ready for impact capital, and figuring out not only how to get them ready along their own trajectory for that, but then working with Investor Circle, which, as Paul mentioned, is an angel and early stage institutional investment network. It's about 20 years old, that has invested in about 260 startup enterprises who have gotten several $100 million from the Investor Circle members, but have leveraged about $4 billion in the marketplace. And we're starting a global health track as part of their work to build this into it, which is pretty exciting, and I'm going to be helping to coordinate that.
So, sorry. First of all, let me apologize, I have a cold. So sorry about that. And second, let me apologize, I'm an engineer. Okay, so I'm not a business major. Now, some of my best friends are business majors. It's okay, but I'm an engineer. My background is in engineering. I graduated and moved directly into the medical device industry. So I worked in the medical device industry for a little less than a decade, mostly working on implantable devices, pacemakers, defibrillators, things like that. But I did some external devices. I designed a heart-lung machine. I did an external infusion pump for insulin. I've done some external defibrillator work. I did some external bone saw work. I've done a lot of medical devices for maybe half a dozen companies, either as working as design houses that do medical devices, or directly for the companies. I've lived and worked in the American medical device industry and the European medical device industry, which are the two, when I was younger, the two only, now still two strongest probably medical device innovation markets. Now I'm a professor of the practice of biomedical engineering at the engineering school. And I run the DHT lab, the Developing World Healthcare Technology Laboratory. We do three primary things in the lab. Well, first I teach classes either in beginning, medium, or advanced medical device design. So almost all my students are designing medical devices. We do three things. As I said, we do a design of new medical equipment. So we've launched maybe 7 to 10 products out of my lab, sometimes spinning them out as independent companies like Photogenesis Medical, sometimes as independent ventures like our Service-Scope, which is wrapped into an existing nonprofit. Sometimes we just add products to existing nonprofit product lines. There are a small number of indigenous, meaning usually African for us, or American medical device manufacturers that focus on the developing world, and we will design stuff for them basically for free. And we've got maybe 7 to 10 products. So that's one aspect of what we do. We also, I place about 100 engineers a year on the ground in either Africa, a little bit in Southeast Asia, or in Central America. Now they do a bunch of stuff, those engineers do a bunch of stuff. Basically, you cannot be an engineer in a developing world without fixing stuff. As soon as people find out you're an engineer, broken stuff comes crawling out of the walls. So you can't avoid that, which is just fine. But one of the main things they do is needs finding, needs identification, and needs defining. Some needs refining also, especially now in the Rwanda program. Our new Rwanda program is really looking at needs refining. But that's a big part of what they do. So we get 400 or 500 ideas maybe back a year from that group of engineers. Oh, and this one thing that we do is research. So the biggest body of research that we have is why do medical devices fail? And it's an amazing phenomena to see something work perfectly, down the street across from my office in the medical center here. 2 weeks later, you see it in Sierra Leone and the thing is broken and you're never going to get it working again. And you need to understand why. The why is the big question. And it's a very, very complicated question, and we've got a bunch of papers. I'm also in the World Health Organization Technical Advisory Group around this question, both on donations, which is one of the biggest, let's see, I don't know how to say it that way. It's a challenging area to get right, let me say it that way. It's very challenging to donate something successfully, yet it remains a very popular way to inject medical devices into the developing world.
I suspect we'll be coming back and we'll try to understand more about these failures. But Karen, why don't you?
Hi, everyone. Thank you for inviting me here today. I'm Clune, and I am the Innovation Advisor within the Bureau for Global Health at USAID. Specifically, I sit in a new center, and the center is called the Center for Accelerating Innovation and Impact. And that was specifically created to bring actually business-minded approaches into the Bureau. It's one of the areas that the Bureau lacks. As you can see, I'm probably one of the other non-business-minded professionals here. I have a public health background, several years in the field. And what we were seeing within the Bureau is that we needed more, I think, insight into markets. We were great at kind of designing programs, funding programs, and launching them, but in terms of actually scaling them and thinking about how they were going to be successful long term, we needed to bring some outside expertise in, and so the center is leading that coordinating role in identifying innovations, introducing them, and then thinking about scale up, identifying partnerships that can help us do that, and bringing some of the best expertise that is out there and bringing that in. Which is really why we're very excited about the SEED program, because I think it provides the expertise, along this whole continuum from kind of helping us think about, what are the challenges in scaling up, to how can we actually help them in the scale up process, and then with the investment piece as well. And so we're very excited about the opportunities that it brings, alongside with the student engagement. I think is going to benefit both the innovators and USAID. I'm sure you guys have all heard the typical opinion that the budget is probably 25% spent in foreign assistance, but in actuality it's really only 1%. And when it comes down to global health, it's much less than that. So there's probably, I think, about 50 million that we get a year, and that's kind of USAID, or I'm sorry, not 50 million, 50 billion that's for foreign assistance across state and USAID, and then actually within the Global Health Bureau, within USAID, and then across the missions, it's much, much less. And so we also see the SEED program is kind of helping us think about, well, if we're making these investments, kind of what are the best investments that we can make, and how can we best support the investments that we're making. So, thank you.
Okay, well, so the first question that I wanted to get people's views about is, why do social entrepreneurs and their supporters focus so heavily on scaling? We've heard the word scaling come up many times. Why don't they just care about making organizations efficient and effective and sustainable, but not necessarily scaling them up? Why do you think there's so much focus on it? I mean, I have to say that I'm relatively new to social entrepreneurship. I just got into this field about 7 years ago. And I taught nonprofit management for years, for 4 years. And I never heard the term scaling up until I came over and got involved with social entrepreneurship. And there's such an obsession around scaling. Why is that? Richard, you're deeply involved.
Let me start. I didn't want to be the one to start on this one because I don't actually agree with the question. I think we're here to talk about scaling. But I think when we start to look in the field, if I look at the innovators and entrepreneurs that we're working with, I don't think they're focusing on scaling enough, and I don't think they understand how to focus on scaling. I think a lot of entrepreneurs would have just got 2 or 3 clinics off the ground. They're based in the slums in Nairobi, or they're based in the villages around Hyderabad in India. Are frankly so focused on how can we just survive for the next 9 to 12 months. How can we design an organisation that is sustainable, that is efficient, it's got the funding flows that we need. I think scaling actually becomes a bit of a secondary concern a lot of the time. And I feel that there's a need to try to integrate all of these operational challenges that these entrepreneurs have with more of the business growth challenges, because I think what one leads to the other, and one also supports the other, and there needs to be much more of a kind of integration strategically about how folks think about this. The other observation that I have kind of around this question is there's a huge number of ideas out there. If you just look in the health delivery space, the Center for Health Market Innovations, which is hosted at the Results for Development Institute in DC, has about 1,500 programs in its database. So there's kind of no shortage of ideas that are out there. There's no shortage of solutions to these global health challenges that we're all very aware of. And therefore, I think that's where the value of folks that have looked at the social enterprise space can bring to this global health arena. And I think that's why this program is so exciting. I think that's why a lot of other funders, USAID is one, Gates is another, Rockefeller's another, that are really trying to systematically look at, let's stop generating new ideas and let's implement what works, and let's work with these folks, work out the efficiency issues, and then try to grow them in a systematic way from there.
Anyone else want to comment?
If you don't mind me just commenting, I also sort of agree with Richard. I don't quite agree with the question exactly. In other words, to me, as you mentioned efficiency, to me scaling up deals with the problem that if you give me enough money, and especially if you give me enough time, I can make any piece of crap my students design work in a given village somewhere in the middle of nowhere. But that's extremely inefficient. You'll give me $1 million or something, and I'll impact 5 people. The issue is if you want me to impact 5 million people, and then I don't know how much money you're going to give me, but even if you give me the same million, you want me to impact 5 million people, that's a much, much different problem. And that difference in efficiency, dollars spent per impact, measured by some measure of impact, is the scaling issue. And what I find happens with my projects is that you reach a certain point where you cannot go beyond without an exponential basically rise in dollar investment per person impacted. And that's when this question comes up. So to me, the efficiency and the scaling are kind of the same question.
Right. Anyone else want to comment? I won't try to defend myself.
Yeah, he has a whole book.
Yeah.
I agree with both of the comments. I think the other thing is that scaling is almost like a euphemism for a whole bunch of underlying issues that people are trying to solve. Is it sustainable? Does the business model make sense? Do you have a revenue model that is, do you have your operational, all the different layers of your operations, do those make sense? Every entrepreneur is struggling with those things every day. We're just kind of putting a wrap on it and saying, this is all in the pursuit of what you talked about. This is all in pursuit of reaching more people more equitably and more efficiently, and figuring out how to do that, where we have this amazing kind of ecosystem where people your students are part of that, promulgating new ideas, and realizing, after 10 to 20 years of that, that's not really making that much difference. We need to do this much more strategically.
I was looking at the semifinalists yesterday for the Echoing Green Fellowships. They were just announced yesterday. Does everybody know about Echoing Green? They have a competition every year where they support a relatively small number of emerging social entrepreneurs or social enterprises. And if you look down the list, I mean, there are just so many ideas there.
Well, I just got into a little tussle, perhaps on the HBR blog yesterday over this issue, where they put out a blog saying what we're really after is great people, and that's what's going to drive real change. And I said, great people is like step one. And then you need a team, then you need a model, then you need like all the things that we're talking about. And they were like, we don't believe in business plans, we just believe in exciting, enthusiastic people. And I was like, oh no. Recognizing every business does need to start with an enthusiastic, charismatic person, but how many have we seen fail when that person can't get their complementary roles that they need around them and can't figure out how to learn and iterate, which is the job of a startup, and to figure out when do you nail something down and when do you decide it's not working yet and you keep going. That's kind of the fundamental process, and the business plan is just laying that out. So anyway, I digress, but it's been interesting.
No, but it really relates to what everybody's been saying. Do you think the challenges of scaling are more difficult in global health, or they're hard in all the sectors in which social enterprises and social entrepreneurs work?
I'm not shy, so I'll be glad to pipe up again. And this is just my opinion, but the regulatory environment around health innovations, and especially medical devices, which is what I focus on pretty much exclusively, is so much higher than in roads. I have friends who innovate in roads. Very interesting, not my thing, but very interesting. In electricity delivery, very interesting. And very innovative, lots of space for innovation. Their regulatory environment is so much lower than what I have to deal with. And unfortunately, it doesn't work by market size. In other words, Botswana, with 2 million people, has approximately the same regulatory burden as Tanzania with 80 million people. But the markets are ridiculously different size. The cost of getting through them is not. So to me, that's a big issue. And especially if you're interested, I like to think that I'm interested and focused a little bit on sub-Saharan Africa as one target. It's 1 million different regulatory environments. With no harmony between them, and what a nightmare. Think about what it takes just to get your P card approval. We here at Duke University, which is when we spend money on a credit card, we got to go through all that stuff.
We have our own initial for it. Did you guys know?
Yeah. Oh my God. And that's just getting started compared to what it is to get a medical device.
In addition to regulatory approval, I think one of the challenges of global health is that health is so intrinsically tied to behavior. And behavior, when you talk about in the global health aspect, is the customs, the culture, and oftentimes some of the behavior may be actually, say for a young mother, it actually might be really tied to kind of what her mother-in-law thinks. And then to scale up means, well, you could go from a community, but then the community next door could have a different value set and belief. And so and changing behaviors is incredibly tough. There's regulatory approval. There's oftentimes when you're dealing with the bottom of the pyramid. So you're trying to get products out to people, and then what you ask them to pay for it, and is there a profit margin? And then there's those service delivery, stock outs, supply chain. It's incredibly hard to kind of get anything to specifically to the last mile. So in some of these areas we're talking about with sub-Saharan Africa, the people who need it most are the ones with far end of the road without electricity and running water and whatnot. So I think global health is extremely hard. The dollars are extremely short, and so all of these things kind of just add up to a package of huge questions and challenges.
I think Karen's done a really good job of kind of laying out the landscape or the minefield as such, and trying to implement, scale, replicate these types of solutions. Just an anecdote, an old colleague of mine from McKinsey wrote to me on the weekend, said, I've got this great idea, I've seen this challenge in healthcare here in the US, here's my great idea. And I had to write back to her, and it was a very long response trying to explain and justify myself, and I said, it's doomed to fail. I said, you will not get anybody to pay for it, there's no incentive to do it, there's no regulatory framework around it, you've got to change behaviors of clinicians, of patients. I said, it's a great idea, it's going to make people healthier, it's going to save the US money that we spend on healthcare, we might be able to get 17% down to 16.8% of GDP. But I said, I'm sorry, don't hate me for saying this. Under the current system, it's just not going to work. And there is just a whole minefield of reasons for that. And I think one of the biggest ones when we start thinking about reverse innovation, which is we're going somewhat away from global health into more mainstream, US healthcare. We look at the question of why aren't these low-cost, high-quality models replicating back into the US? And it's the politics, it's the policy, it's the regulation. It's the fact that, frankly, if you look at a big health system, and I say this in all of my talks, at some point I'm worried somebody at Duke Medicine is going to turn around and tell me I'm not allowed to say this. But it's the incentives within the health system like that. The entire structure of the US health system has been set up around providers such that folks are incentivized to do more volume, to do more tests. I've had friends and colleagues go from the US back to the UK and wonder why all of these tests aren't done, but we're still living healthy lives. And it's that comes down to patient behavior. If you walk into a hospital, you expect to be dealt with, you expect to have all of these tests run. There's no incentive to kind of move towards wellness. And I think unless you can, deal with this human behavior element to all of this, and I think it's actually more of an issue around patients. Everyone thinks the issues around clinicians. I think the issue's more around patients than clinicians. If you look at developed world healthcare costs, about 70% is driven purely by chronic conditions, and about 50% of chronic conditions are driven by behavioural choices. And the four most straightforward ones is exercise, food, alcohol, and tobacco. If you can deal with all of that, you're down to 8% of GDP on healthcare.
No problem.
Okay.
There we go. We'll put Cathy Clark in charge, the senior advisor to the State Secretary of Health for getting the spend on healthcare from 17 down to 8 in the next 4 years. There we go.
Well, given all the minefields and obstacles, yeah.
I just want to mention there's another complicating factor of health, global health innovation in resource poor settings, and you started to touch on it, Richard, a little bit. In the developing world, most countries that I work in have at least, as a minimum, a two-track system of healthcare. There is actually a private healthcare system, which is often quite robust, in fact, and it can cover from people who can get an MRI, pretty good basic care, to even people in the most remote village that will pay for their healthcare rather than have to go to the public system and wait. So there's this complicated private system. Then there's a public system, which is usually a socialized medicine, probably more like what you're used to in an English system, not so much like you're used to in an American system. And then there's often a donation system, maybe faith-based. It depends exactly. And these three systems don't necessarily work together, or if they do work together, they don't necessarily work together well. And even if you are only interested in this particular slice of the population, they may be served by all three for different healthcare needs. And this is not what you're used to. If you want to introduce a product in Europe, you go to this one regulatory agency, get it approved there, then you go to the national health system in Britain, get it approved there, and then it can start rolling out. And that's pretty much it. And that doesn't even talk about going between countries. That's within one country, this complicating factor. And one more thing, I'm sorry to take up too much time here, but another thing is that there are usually these key stakeholders. We're talking about behavior change. There's these key stakeholders which are actually deciding essentially most of what is delivery for the healthcare. They aren't necessarily in the sector that you're interested in serving. They actually could be in the private sector, but you're actually interested in serving the public sector. Nevertheless, they are key stakeholders. So then, of course, that complicates sort of the financial background behind all of this. So that's another complicating factor that as a medical device innovator you may not be used to.
So don't get scared away, because the challenges are very exciting. But can you identify any organizations that made it through this minefield that you feel are exemplars of effective scaling? Or are we just left with a bunch of promising organizations that we hope to move through a pipeline and lead to scaling? Is there a shining light out there? Are there bright spots out there that we can refer to? I mean, they're the ones that have cases written about them, like Aravind, Vision Spring, and so on. But have they really achieved that much in terms of scaling? Do we want to use those as the example, or are there others?
I can start.
Yeah.
So
I see you have notes.
I have notes. I
I figured you had an
read them
answer.
from
I
there.
agree with your notes as
You
well.
agree with my notes? Great. So we'll see. Like, how many different categories? So I was going to say Araband, I think, is a great example. If you guys know Araband, we're going to study it a little bit later in my social entrepreneurship class, and some people here have done that already, and some people are about to do it. But Araband is an eye surgery innovation which is highly efficient and cross-subsidizes paying patients to give care to free patients at about a 50-50 ratio, which is extremely high, right? So people can walk in. And we study them as part of a framework on scaling here because they've used every tool in the toolbox that we can look at. I don't want to get into that too much, but I think they're tremendously successful. I don't know if they're in your book yet, but success. And I think there are examples of other innovations that are starting to approach that level of success. I think there's an organization, a company that I've been following for a little while called eHealthPoint, which I don't know if you're familiar with. It started out with kind of a dual business model, and they ended up kind of testing two different lines of business, and after a while realized that one line of business was working really well and one wasn't, so they took one and wrapped it up as a for-profit and got a whole bunch of investment, and they took the other and put it into a nonprofit and said this is going to be slower. It was about creating these points in BOP markets where you could both do some sort of kind of telemedicine service, kind of patient delivery on site, and also treat your water. So it was like this very interesting dual kind of thing. And it turned out one worked and one didn't. But when you talk to the entrepreneur who founded it, they started from the very beginning saying, this is not going to be successful unless we are a global entity that serves at least 5 to 10 countries, and we're going to develop our supply chains, our internal systems, everything from the beginning with that in mind, which seems really interesting to me as kind of much different from where other people start, which is, what we were talking about before, which is you get to work in one place and then you go, how do I become more efficient? And so I think there's some good lessons there. Some of the other ones that I noted down that I think are interesting, Vision Spring, which is a low-cost eyeglass, has been for the past few years a low-cost eyeglass distributor, I think has not been tremendously successful at figuring out how to scale until very recently, where they changed their whole business model, which is again really typical for a lot of these social entrepreneurs, and they figured out that they actually have to offer ophthalmology services.
They were just selling reading glasses.
They were just selling reading glasses, and they weren't able, even though there was basically a huge spread between the dollar of their cost and the $35 price in many of these markets for other glasses, they couldn't figure out how to make it work. And so there's another lesson there about kind of, can you be a one product company, or do you need to be something else? And then there's other newer players like Embrace, which is a infant baby warmer company, which has kind of gone whole hog and said, unless we're going to scale up really dramatically and try to be available on a broad basis, it's not worth for us to exist. And they also have bifurcated so that all their R&D stuff is in a nonprofit, and they've gotten really big Silicon Valley investors in their for-profit to scale up really fast. So I think there are some examples.
In the saving lives at birth sector, are there some shining lights there?
We have several shining lights, and maybe more kind of, instead of looking at the actual organization itself, maybe looking more at the innovation.
Sure.
Because we've also found that a lot of sometimes innovations are, we promote like partnerships. Maybe it might be the nonprofit partnering with a for-profit for, say, the Ministry of Health in the country. Chlorhexidine is a great example. It's a solution that you can put on the umbilical cord after birth, and it prevents infection. It was shown in Bangladesh. It was first introduced in Bangladesh. They did some trials, I think, through Hopkins, and it was shown to reduce infant mortality by 24%. Bangladesh got very supportive and excited about it, and then it started scaling through a variety of NGOs, probably most predominantly JSI, in Nepal. And that has also shown a dramatic reduction in neonatal mortality. But a lot of it, and the reason why it scaled so successfully, is this partnership behind it. So it's it's the NGOs who are working with kind of also local NGOs. The Ministry of Health, they have strong buy-in, partnership, everything they've done. They've had a local task force that has worked behind this with the Ministry of Health. And then they got a local pharmaceutical manufacturer who actually makes the product in Nepal. And I think they sell it for maybe 10 cents. The profit margin is really low, so they've had difficulty trying to think of how they can take it perhaps to other countries. They're now looking at how they could scale, take chlorhexidine into Nigeria. And the idea is, do we find a local manufacturer? Do you have a regional one? Do you take it from, say, Asia and bring it over to Africa? Exactly how do you work all that out? But there's a lot of movement, a lot of support behind it. There's regional chlorhexidine meetings now about how we can improve this product. And so that's we've been funding through the state of Mysore and USAID, and several others are also behind it as well.
Good example. It's a different form of scaling than scaling an organization.
Mm-hmm.
It's scaling on being
Yeah, I think that Safeway and Uniject would be another one.
Yeah.
So started in the nonprofit world, got taken up by BD, now they made billions of units of that. But if you look at product, there are actually quite a few, in my opinion, success stories.
On the service delivery side, one of the organisations that we find the most exciting is One Family Health, which is a franchise nurse-run clinic model in Rwanda. And it had its roots back in Kenya under the auspice of the Health Source Foundation that runs child and family wellness clinics. And they really focused on kind of back to the first question, this whole question of efficiency of the clinics, efficiency of the supply chains, really thinking about honing the model itself, and less on some of the conditions or the factors necessary for scaling it. So over the space of about 8 years, they got to 80 clinics in total. And each individual clinic broke even, which was important for the local nurse entrepreneur, but they never broke even at the central level. And they'd never had the right kind of mindset or vision to think about what does this need to look like, kind of back to the point we were making about e-health point services, of almost kind of having the end vision in mind and then building the organization up that way. And there were kind of 3 core lessons that when we look across all of the innovators that we work with really epitomizes the ones that are ready for scaling and doing pretty disruptive things in global health. The first is around this long-term vision idea, this articulation of what a need is and what good will look like in 10 years' time, and really starting with the end in mind. The second is around principles and lessons, success factors that other folks have done, either in the social entrepreneurship space or in the broader global health space, and thinking about how do these translate onto the ground. And then the final is around this whole regulatory policy incentives type of space, and having an acute understanding of how your organization is going to work within that. So as this model moved from Kenya to Rwanda, they understood these three areas, and they knew that in Kenya, the middle area around lessons, principles was great. They had learned from McDonald's, Subway, how to do franchises, all of this great stuff. And they said, well, as we go into Rwanda, we know that to be a sustainable organization, we need to have a certain amount of volume. That's the only way that a franchise model is going to cover its central costs, is if you've got enough clinics around the country. And they knew the only way that they could do that was if they worked directly with the government and with an insurance system to get around all of the reimbursement and political issues. So they went into public-private partnership, and they said, we guarantee that over the next 5 years, we're going to build out 300 to 400 clinics in the country. They then worked with GlaxoSmithKline on the whole supply chain mechanisms and got funding from Glaxo as well as EcoBank in order to set this partnership up. And it really was, if you look at the Kenya model, then it's not scaling. It's got to 80, it's plateaued there for about 5 years. But if you look at the Rwanda model, it really is at the point of scaling. It's really poised for success, and it's got from I think 5 clinics to about 30 or 40 clinics in the space of 6 months, and it's just going up and up and up. And I think it's those preconditions about having that long-term vision, understanding the principles of efficiency and effectiveness, and knowing how this plays in the broader health ecosystem, and finding the right role that helps guarantee its pathway in the right direction.
Any last comments from the panel before I open it up? We have till what time?
Till 11:40.
We have a lot.
Yeah.
All right. Well, does anybody want to ask some questions at this point? I have some other questions I can ask. Yeah.
I have a question, and Bob, you kind of mentioned earlier some of the work that you have done is on failure and why things fail. And I do think there's this kind of inherent belief that, oh, we can take something from here and make it work someplace else, or we can learn a lesson from one country and apply it someplace else. But it seems that in the interest of being efficient and sustainable in our efforts, we should know ways that just doesn't work, or that don't work. And so I'm curious, from any of your experiences, what are those lessons learned and what to avoid, or perhaps some of your research insights?
Yeah, so I'd be glad to start off with a comment that I'm sure will have some great insights in this. It is absolutely true that, in my opinion, there's a certain body of people, even on this campus, that think that if it works here, it's got to work there, which is not true. There are probably 2 to 3 major reasons that medical equipment fails, at least for the medical device and medical equipment side, fails once it gets there. The first one is certainly that the economic model in the U.S. is largely based on medical equipment anyways. On medical equipment is a device that addicts you to a supply chain. So, I sell you an infusion pump, or I can give it to you, but you can only use these little plastic jobbies that's sticking in one per patient. And that model is terrible for the developing world because they just don't have the money to pay for that kind of equipment. So just for example, infusion pumps have now completely changed that economic model. When I started in this business, I could barely get people to give me infusion pumps for the developing world. If I did, they worked. I can get as many infusion pumps as I want, but they're pointless once I get them there because I can't get the little jobby that sticks inside them. So that whole business of, and that's just one example, it's also a clinical lab, that whole business of how are you going to supply the machine itself. And that includes spare parts, which is essentially an untouched area. One of the problems with medical devices is they all break. One way or another, they all break. Just like your car, your TV, your laptop, everything breaks. Somehow it's got to get fixed. In the U.S., perhaps not, because you throw away your car or your laptop. But in the developing world, not so much. Most devices of even a very basic level, even cell phones, for example, you see people carrying cell phones. And so that's the second area, is that the entire area of the support system, which is basically a capacity building question. You need people who are trained to operate the device, trained to operate and repair the device. And at least for medical devices, there really isn't the culture that we have in the U.S. For example, 34% of broken devices in the U.S. are the user does not know how to use the device. So they're using it inappropriately, which, by the way, is 25% in the developing world. So actually, in the developing world, they do a better job than the guys across the street over here in this. But that's still a huge fraction. And, that there's a bunch of intricate points around that, but at least one of them is there's no culture of, a physician, for example, who doesn't know how to use a device saying, oh, I don't know how to use this, maybe I'll go ask someone. There's not a culture around that kind of thing. And then, the last piece, which is a huge piece, and we see 15 to 18%, it depends a little bit, simply inappropriate in the first place. It just doesn't belong there. They don't have the clinical need. They don't have the expert who actually knows how to use the device, for example, read the x-ray film or whatever. They don't have the patient's body, they don't see those kind of patients. And do you think that would never happen? But it happens a huge, 10-15% of the time. That's the problem. The innovation never made sense in the first place. Or the donation, or usually ends up in donation. So those are some of the kind of things we've been investigating and discovering and talking about.
I think also, within global health, the outcomes are so intense, and you're talking about lives saved, that oftentimes there's kind of a balance and a pull between pushing out an intervention or a product or something perhaps a little bit too early without actually thinking through how to introduce it properly. For instance, the female condom. I'm not sure how familiar you guys are with the female condom, or if you've not asking for too much information if you've ever used one, but like the design is actually quite poor. It's squeaky, and also they saw, you know, the real need for it was at the time they thought for female sex workers, and so that was their target market at the time, without thinking that if they wanted to market this product to a non-female sex worker, now it kind of has a stigma around it that it's just for female sex workers, and they're having difficulty, say, getting it into other markets, and also now there's interest in, like, do we bring it here to the United States and whatnot. So I think that there's this balance between you wanting the product out there, you're so excited about it, there's potential great results, versus really thinking through kind of the demand piece and whatnot.
Hey. Sean Moore, I work at Acumen Fund, and I'm the portfolio team there. And so we invest in healthcare space, actually Vision Spring, one of our investments as well. But I'd be interested actually in the SEED program. Are there specific sectors within healthcare or specific diseases or topics that you're focused on in terms of scaling up, or is it just a broad public health issue right now? And how do you see kind of getting to the point of kind of, are there specific areas that you see are the most impactful or have the most potential to be most impactful?
Richard's been choosing our first cohort with input from others.
It's a timely question.
Yeah, that's a good question, and it was something I wanted to kind of pick up on the question before as well. So the answer to your question is we're pretty broad at the moment. You know, the types of entrepreneurs that we're seeing the most of is around primary care, specialized care, maternal and child care, some infectious conditions, but we've been kind of, you know, quite across the board, and I think that you know, back to the question and kind of looping it into what you've just asked, I think part of the challenge is how do you kind of step back from where we are and ensure that we're scaling the things that matter. I mean, even the kind of conversation that we're having right now is all really on the premise that we've built something or we've identified something that should be scaled. And actually, quite frankly, even if you look at a lot of the organizations around the world, you know, I think it brings it back to the question of, is there really a need for scaling what we're scaling? Are we scaling the right thing? As well as, is it something that can be scaled? And I think as this program kind of evolves and goes forward, and this is, you know, part of the reason that we wanted the Global Health Institute to be a kind of core pillarstone of this, as well as you know, working with our colleagues at USAID, is to, you know, really better understand the landscape of where innovation is needed. And then using the expertise and the skills that we've got across this consortium to start thinking about what are the ways of scaling things. Because unless you start with the question of what is the need, you know, what is the opportunity, what are we trying to solve for, you could end up just scaling things that don't need to be scaled or aren't appropriately scaled.
Other questions, Rick? Yeah.
Just building a little bit on these last two questions, I was thinking about, as we've talked about failures and what's you know, trends and sort of what seems to be working better and things that are been sort of classic pitfalls, I think, of past global health efforts. What's the role of the funding source in all of that, and maybe incentives or disincentives that are sort of associated with some funding sources more than others? And what are some of the changes that maybe are happening already with different kinds of capital coming into the space of global health, or different new mechanisms as an opportunity to avoid some of those pitfalls? It's kind of broad, but I guess I'm thinking a little bit about, you know, that you mentioned donations still happening of things that are completely inappropriate, or sometimes maybe the pressure to introduce an innovation before it's really ready. Are there different sort of types of funders that tend to be pushing some of those failures, I guess?
I mean, I
with all the best intentions.
Yeah, I feel like I'm still kind of in the early phases of understanding the global health funding space. It's, you know, been kind of one slice of what I've looked at for a while, but hopefully we'll get a lot deeper as we start to build this out. I feel like there is probably, and I'd be interested in what Sean or others think, I feel like there's you know, in all of these spaces, we have this kind of ideal spectrum in our heads of who's going to provide what kind of capital along the way, and there's just huge gaps whenever you look at any one particular space. I think what's different, that's occurring to me that's different in some of the examples that I've studied in the global health space is how significant government's participation is and how that can be both helpful because it can fill a gap, it can also pervert people's interests. And especially if that government funding stops right away, and then you're all of a sudden to kind of, you know, forced to work with a national government in a different way, right? You have a bunch of different clients when you're trying to figure out, you know, are you part of one of the systems that you talked about? You talked about the public-private. You know, are you trying to integrate into one of those systems, or are you trying to, you know, kind of convince them that they should be doing something different, which is very, you know, they're not going to pay you if they're not convinced yet, right? And so I think you have kind of a funder customer mishmash going on, if that makes sense. So I don't know, Sean, if you have any other things to add to that.
I think I pretty much agree. We've had a couple of interesting investments kind of right in this space, and I'm particularly, I sit in our New York office now, and I'm actually looking at a couple early stage medical device companies and really interested in that. And there's definitely a gap, even for us at Acumen Fund, as we think internally how our capital can be used. And I don't want to take too much time, but I don't know if everyone's familiar, but we're a social impact investor, and so we're pretty much backed by philanthropic capital. So that allows us to take that in earlier stage risk investments that don't have the upside, the financial upside that traditional venture capital is looking for. But even for us, because we're investing in developing markets, international markets, very early stage, we're taking on that risk. Our kind of investment committee is still a little wary about taking on the added risk of early stage medical device innovation, especially because of the regulatory system is so kind of complex. And so how do you actually get to an approved product that can be then, you know, bought by the multilateral agencies?
I had one other thought, which I have a hypothesis forming, which I'm not sure about yet, but I'll share it with you, which is that I think these two communities, I think there's kind of the service company and the product companies are going to be entirely different in terms of the stakeholders and incentives that align around getting these people through. And I think the private sector understands products. They think they understand products, but I think they're more likely to fund product development and distribution because they get that than service delivery, which is necessarily interacting with government systems and other systems. And I think that's going to be a longer road to bring people through.
Your question also reminds me there's actually another HESN, so as I mentioned that Duke is part of this larger network, and so there's 6 other universities that are in it. And William & Mary won a large grant for they're doing some mapping, GIS mapping. They were looking at, I think it started with, you can correct me if I'm wrong if you guys were there for the presentation, but it started with a student who was doing, I want to say she was consulting for the World Bank, and they had asked her to kind of map out where all their investments lay within one country. And then map that against, say, the need and kind of the disease burden, and seeing, and it was, it's actually quite stressful, I think, for a funding organization when that was going to happen, because it's like, oh my gosh, I hope we're making the right decisions, or I hope this actually all works out. And so then it's just one thing to take the World Bank and all their projects within one country, and then you layer on it all the other funding organizations, and are there, will you see, for instance, in one specific district that there are a gazillion, maternal health projects, but actually the maternal mortality is much higher in another area where there's perhaps, less partnerships and less roads, and so it's more difficult to get to. And I think it just goes back to the fact that the funding, for in the public sector, the funding organizations need to talk better. And make sure that we are strategically, collaborating or working on, perhaps separate things. As Paul mentioned, I work on the Saving Lives of Birth Partnership, so it's leveraging dollars from 5 different organizations: USAID, the government of Norway, Canada, the Gates Foundation, and DFID. And it's saying if we each put in $10 million, what could we possibly do? It's the outcomes are much greater if we have $50 million to play with in terms of finding maternal and neonatal health prevention. So I think I think more partnerships are developing like that amongst the private sector to see what we could do with just putting in a little money each.
One of the other things that I feel is missing in this whole area is some kind of intermediary between the kind of service delivery or innovator side, as well as this whole investment funding, very, very broad side as well. I think when we look at the service delivery side, there's still a lot of folks that are kind of bootstrapping changes. There's a lack of information of where the money is available. How do you get this into the organisation? How do you become prepared just to work with an organisation like Acumen, have everything in place? How do you get the value out of that type of interaction? What are some of the alternative funding sources? Because I think most service delivery innovators would kind of think of IFC and Acumen as the two to think about first, but aren't kind of aware of some of the other opportunities. I think there's also a lot of challenges on the investment funding space, and myself and Cathy have been trying to wrap our heads around this to work out what type of role seed plays in this. But how do you get the right funding in the right places on the ground that can put money into these things? How do you create then a win-win situation for both sides? Something that is investable in India is just not investable in Africa at all, and requires other organisations coming in. I think there's things that the private sector can do differently. I think one great example is GlaxoSmithKline, who's one of the only organisations that set up an entire business division. And when this is a business division, not a corporate function, it's not CSR, but it incorporates both the business mindset as well as CSR. So they have their entire budget that they can invest into different partnerships, collaborations, and opportunities. And they're measured on volume in the 50 least developed countries in the world. So they're not, they haven't got the same incentive systems as the rest of the pharma sector. They're incentivized by a number of drugs that they get out to the poorest folks. I think it's the poorest 2 billion individuals on the planet. And that's quite unique. There's other organisations aren't doing that. So I think we're starting to kind of move in the right direction, but that lack of strong intermediaries in the middle that can understand both sides and try to develop them in the right way, I think is part of the driving challenge behind a lot of this.
Sure. If I could just jump in a little bit on donation, because it's an area that I'm particularly interested in. 2 studies that I want to mention. We did one that we published in the last, 2011, so we did before last. 112,000 pieces, 66 countries, in hospitals. So that's only one service delivery element. A couple of important findings from that study is, first of all, 95% of the bill was coming from outside the country. Or you can look at the optimistic side. 5% of it was actually developed within the country, which is more than zero. But we now have another study that's going to come out soon looking at donated, specifically what fraction of those 112,000 were donated, and we're tracking only about 10,000 of those, where we can actually track them all the way from the donor dollar all the way to the patient bedside. And just a couple of small tidbits about the power of the donor in distorting this whole system. Donated new equipment was far less likely to be operating at the patient bedside than donated used equipment. And purchased new equipment was far more likely to be at the patient bedside than any other system. And that includes if an organization donated the money to the Ministry of Health and then used it to buy stuff. That didn't improve it any more than if they just bought the stuff and put it in place. There's also a few organizations that have done things like putting on service contracts and these other things which appear that they must do things. They actually make it even worse. So the worst category was donated new medical equipment with service contract. That was the most likely to not be at a patient bedside. And then we could have a long discussion about why that is. But at least one reasonable hypothesis is that the donor dollar dramatically distorts the way the good flows through to the patient bedside in a way that, at least at the moment, I don't know how to even suggest solving, except for, keep in mind, there are a few countries which are seriously considering banning donations altogether. Maybe that's the way to go, I don't know.
Gentlemen,
You have some very impressive projects there, and I'd like to ask a bigger picture question about, has anyone sort of scaled this concern for public health up to the topic of economic development? In other words, you know, you can build a factory there, which employs a lot of people, pays taxes, but it pollutes the air and the water, or it affects the health of the workers. So I wonder if people have taken this topic to the point of saying, if you want to do economic development, here's the way to do it with the most health-conscious way, I suppose.
I mean, in some ways, that kind of issue comes up when a country decides we're going to invest in a brewery, or we're going to have a tobacco company enter. We're going to get a lot of economic development, we're going to have a lot of jobs, but then we're going to make everybody sick or drunk. So these issues come up all the time, but usually the economics wins, and health comes in second. More generally in healthcare, you have lots of different philosophies about what's good for people, both in terms of alternative philosophies about medicine, alternative philosophies about how do you care for people who have different kinds of diseases, and lots of different therapies can have unintended effects that, for example, I've studied nicotine replacement pumps, and I've discovered that when people get told that there are all sorts of new products that they can have to help them quit smoking, they keep smoking. It's what we call a get out of jail free card effect. And so just the whole healthcare sector has all these cross currents and different philosophies and different things pulling on people, which makes it extremely difficult to scale.
I think part of the challenge is that if you ask the question, whose problem is health, not just healthcare, health, whose problem is health, most people at kind of a macro level would say, oh, it's the Ministry of Health. Ministry of Health is responsible for anything to do with health, anything to do with the health system, well-being, all of those types of things. And I think there's a real need to reframe that it's not just the healthcare sector's problem, it's not just the Ministry of Health's problem, it's everyone's problem. I mean, there's been plenty of work that's been done, and I've been sitting on various working committees at the World Health Forum that's looking at, if you want to move towards sustainable health systems, if you want to deal with this kind of 17% of GDP figure that I've banded around a couple of times now, you need to make it a broader economic issue. You need to make sure that the Ministry of Finance, Water, Agriculture, all of these folks are aligned around what needs to change. The biggest driver of health system costs in the developed world, is not through the kind of quote-unquote health system. It's from unhealthy eating. It's from alcohol, tobacco. The lack of exercise. I mean, one of the anecdotal things that I just found kind of very surprising. I know that London is a big city and Durham is a small town, but it's the lack of sidewalks around Durham. It's actually difficult to walk around this town. Everyone drives. It's the kind of food. I mean, back in London, you can kind of point to alcohol as being one of the kind of biggest health issues. But these are all bucketed under this Ministry of Health. And until we can kind of break that down, involve more stakeholders in it, and look at the research and understand the data that shows this is an economic problem, it's not just a health problem, I think we're not going to make the right necessary movements on the question that you just posed at.
Karen?
Karen, this kind of expands on what you were talking about with collaboration. Mm-hmm. What is USAID's plan in terms of, who's involved with the peasant participants in making sure that there is collaboration with the entrepreneurs that are working on global health, so that when they're scaling up, it's not a bunch of duplicitous efforts. Mm-hmm. I guess I'm thinking back when I was in the Peace Corps, you have USAID that's bringing in donations, and then you have religious organizations that are doing their thing, and they're all trying to help with maternal mortality. Mm-hmm. But then I'm working with the midwives, and they're not adopting any of them, and they're still doing what they're doing. So making sure that there's best efforts that are being shared, and what is kind of the plan with that?
And I think there's probably a lot of different there's a lot of different levels to that. So broader amongst HESN, the HESN sits within our science and technology office. So without going into too many details, so there's a core group in there who's involved in making sure that some of the best practices. I mean, it is a network, and there's a reason. Like they want to make sure that all these universities can really leverage the expertise of each other and kind of grow into something bigger than one university alone. And so the Office of Science and Technology is really devoted to kind of bringing together and seeing ways that universities can collaborate, or if someone is having a meeting, can you bring in another university? And can the students engage? Are there opportunities like that? And then even within, I think, then the question is, there's another layer, like within USAID, how can we make sure that some of this knowledge is then disseminated? And so we need to have, or we, are inviting and offered to have, we want to have the groups come and speak within AID. I sit in the Bureau for Global Health, so I act, daily with the Office of Science and Technology to make sure that some of those kind of the HESN information trickles down to Global Health, and then I spread it within Global Health to make sure that there's that knowledge that's shared. Because the Duke grant is specific to Global Health. I think that some of the lessons are much broader applied. There's a grant on, I think, food security, and there's the mapping one, and some of those best practices I think can also be applicable to Global Health as well. So there's different layers, I think, and there's just a lot of right now active communication, both, as I said, within HESN and then also down to kind of like the different bureaus that are all communicating.
So it was really interesting to hear all of you saying that you feel like there are too many ideas in global health, that we have to stop thinking and implement, because from the global health world, that's very scary. I mean, we think about there being some myriad of too many things that need assistance, that we haven't figured out the right thing to do, or there are 3 or 4 strategies that need to be deployed and very careful timing to get anything done. And in hearing some more of our discussion about social entrepreneurs in global health, it struck me that a lot of what you can tangibly invest in an entrepreneurship framework are brick and mortar operations like a maternity clinic or a pharmacy or something like that, or a product. And global health is so much more than product and brick and mortar, and in fact, if we have too much of those things, not proportional to the thoughtfully planned healthcare system in some of these places, I don't think we'll achieve our objectives. So as a group that's going to be focused on how to support social entrepreneurs, what are we going to do to kind of zoom out and say, where are these people playing in the entire ecosystem? What else is needed that maybe isn't directly going to be through an entrepreneur that can build the system a little more instead of a lot of products and a lot of offices?
So I think that's a brilliant question. And I think this kind of comes back to the point that I made earlier about needing to start with the need and the issue in mind, and not starting with, we've kind of got a great service delivery model or product and technology, let's just scale the thing, take it to however many people, because in fact, to Bob's point, you could end up kind of helping 10 individuals with $1 million rather than a million individuals with that. So I think you have to start with the need, and you have to get the right stakeholders around the table. One of the organisations I don't think that Cathy mentioned, but is on her bit of paper, is Riders for Health, that provides logistical and transportation infrastructure in Kenya and other parts of the developing world. And part of the challenge that they've got in scaling their model is trying to convince government that government should be putting the budget there, should be investing in proper infrastructure, logistics and transportation in order to get health workers out into the field. I don't think this is something that can be just solved with social enterprises. I mean, there's certain things that social enterprises can do, certainly can't do. But I think then when it comes to the other stakeholders, and that's kind of donors, that's government, that's other community organizations, it's how do you get them, how do you make it kind of clear what are all the different needs within a country, and then who's in the best position to deal with these things. And I think it kind of goes back to Carolyn's question as well, which I would kind of build on by saying, well, there's maybe a couple of issues here. There's this kind of, not just how do you make sure that money's going to the right place issue, but there's also this kind of coordination issue which I don't think is being resolved. And I think the only way it's being resolved at the moment is through different NGOs and organisations and other stakeholders talking to each other regularly. But I think that somebody, I don't know if it would be World Bank, AID or whoever, needs to almost play some kind of a coordinating or convening mechanism. Or you could end up with the situation we've got at the moment of various initiatives focus on the same thing, trying to kind of put the same dollars to the same place. But it's this need to step back, understand the need, see the big picture, and then focus on what you do best. Don't get involved in what you don't do best.
And I would argue that maybe some of the, yes, global health has a lot of innovations and very successful. We know there's tons of best practices. Maybe some of the innovations that are needed are actually addressing that gap. So how can you, if there is a successful product or is a successful intervention that's out there, how can you maybe innovate around the health system or provide that missing transportation device to get someone to the healthcare facility?
Well, great.
Patty, everyone?
Yeah, so thank you. I just wanted to say thank you all for attending, and thank you to our wonderful panelists for